Welcome back to ACCEL for May 2014. I'm Alfred Beauvais. Disc 3 begins with a discussion Richard Conti had with Dr. Paul Ridker, the Brownwell Professor of Medicine at Harvard Medical School in Boston. They cover cardiovascular inflammation reduction trial, CIRT, a randomized clinical trial investigating if low-dose methotrexate reduces heart attacks, strokes, or death in people with type 2 diabetes or metabolic syndrome with previous heart attack.
Welcome, Paul.
Dick, it's always a pleasure to be on ACCEL with you.
Paul, now, what's the rationale for this trial?
Well, Dick, we are really excited to have gotten the funding from the National Heart, Lung, and Blood Institute to do what we think is really a groundbreaking and pivotal study in understanding the role that inflammation plays in heart disease, and more directly, whether lowering that inflammation might lower the risk of heart attack and stroke for our patients. So the fundamental issue in CIRT, the cardiovascular inflammation reduction trial, is to directly test the inflammatory hypothesis of atherothrombosis.
How are you going to do that? What are the entry criteria for patients?
Done by our group and others over the last decade have shown that people who have this pro-inflammatory response, both in primary prevention, that's what led to our Jupiter trial, but also in secondary prevention, people who've had a prior MI who have inflammation, defined either by a high CRP or by the presence of diabetes or metabolic syndrome, because these are conditions that we know have high CRP levels and are very associated with inflammation. In CIRT, we'll take patients who've had a myocardial infarction at any time in the past 5 years, who have either diabetes or metabolic syndrome, and are currently stable, all on a statin, and ask the question, if I give them standard of care plus placebo or standard of care plus low-dose methotrexate, can we lower vascular risk? Now, low-dose methotrexate is in wide clinical use by millions of Americans who have rheumatoid arthritis. This is the dose of methotrexate that's very safe, very commonly used. We've got nearly 40 to 50 years of therapeutic data on how to manage it and how to control it. The American College of Rheumatology has excellent guidelines on how to manage the drug. The question for us is, if we give this anti-inflammatory drug to people who've had a prior heart attack, can we actually reduce, not CRP levels, but can we actually reduce rates of recurrent heart attacks, strokes, and cardiovascular deaths?
You answered two of the questions that I had, is that's what's the rationale for using methotrexate, and since it's a cardiovascular audience we're talking to here, methotrexate, we sort of recall being a drug to treat cancer, but certainly our rheumatology colleagues use it for rheumatoid arthritis as well. How often will you give the methotrexate?
Well, your point, Dick, about differentiating this from cancer is crucially important to understand. When we think back to our days of training when we use methotrexate for certain oncologic disorders, the dose used there is orders of magnitude higher than we're talking about here.
Sure.
We're talking about doses of between 10 and 20 milligrams per week. This is the dose of methotrexate used to treat rheumatoid arthritis or to treat psoriasis, given once a week, typically on Saturdays, and the rest of the week the patients take folic acid to improve the side effect profile of the drug. Methotrexate turns out to be a very interesting anti-inflammatory agent in terms of atherosclerosis. One of the most important pieces of evidence in favor of this trial is that there are 7 different observational studies. Now remember, these are observational. They're not randomized. And they're data from arthritis clinics around the world where the physician chose to give one rheumatoid arthritis patient methotrexate and the other got some other disease-modifying agent. And in every case, there's actually a reduced vascular event rate down the road. So there's this observational evidence saying when people get a systemic anti-inflammatory that we know is pretty safe, there seems to be lower vascular event rates. But of course, that's non-randomized. And then our vascular biology colleagues have delivered really quite extraordinary data, again, in animal models, telling us that if you take, for example, the cholesterol-fed rabbit and you pre-treat with methotrexate, you can actually inhibit the adhesion and attachment of innate immune cells, and you can actually slow down the progression of atherosclerotic development. But again, that's an animal model. So based on the basic biology of inflammation, atherosclerosis, based on this observational evidence, we think the time has come to actually do a straight-up randomized trial.
Is there any downside to using methotrexate?
Well, the trial has been negotiated with the NHLBI really as proof of concept. Can we show that giving a upstream targeted anti-inflammatory drug might benefit our patients in terms of fewer heart attacks, fewer strokes, fewer cardiovascular deaths? Methotrexate, of course, does have side effects that are well known. We can have issues with dropping white blood cell counts. We can have issues with infection. So the trial is following this very carefully using a sophisticated algorithm that really follows what our rheumatology colleagues do in their practice. I think one issue is that this is a relatively broad spectrum anti-inflammatory. And if it works, we would ask the question, would that now open the floodgates, so to speak, to have more targeted anti-inflammatory drugs looked at? So it's a proof of concept study that we hope would deliver a new, generic, inexpensive treatment to our patients.
How many centers are being recruited for this trial?
Well, Dick, I really appreciate your asking that because I know that your own center has elected to be part of the study, and frankly, I'm very proud to have you as one of our PIs. It really says to us that the science is exciting for you. We will have around 300 centers in the United States and Canada when we have this worked out. Those centers are now being recruited. We've had 2 investigator meetings, and we're really excited about just starting up.
What's expected of these centers?
Ultimately, we need 7,000 patients across the United States and Canada. And those 7,000 patients will be allocated to either active methotrexate or to methotrexate placebo and followed for an average of about 2.5 to 3 years. And the primary endpoint of the trial is the one that really matters to us as docs. If I treat with this anti-inflammatory, will we at the end of the day have fewer heart attacks, fewer strokes, fewer cardiovascular deaths?
So those are the primary endpoints, right?
That's correct.
Okay, what's the duration of the trial? How long will you follow these patients?
Each patient's going to be followed for an average, we figure, of about 2.5 to 3 years. And given the length of the study, the whole thing should roll up in about 5 years.
What are the secondary endpoints?
The secondary endpoints reflect the tremendous interest at the National Institute of Health about what happens when you inhibit inflammation on a systemic basis. The most important one to a cardiovascular community is diabetes. Remember that diabetes is also a disorder of innate immunity, but affecting the pancreas more than the vasculature. And of course, we've known for many years that biomarkers like CRP not only predict heart disease, they also predict incident diabetes. So I think the most important pre-specified secondary endpoint is the rate of progression to diabetes among those who enter with metabolic syndrome and the amount of diabetic medications required during the course of the trial for those who start with diabetes, the hypothesis being that all indices of diabetes will probably improve by inhibiting inflammation. Then there's also a series of secondary endpoints that have to do with other vascular disorders that we know are associated with an inflammatory response. For example, supraventricular arrhythmias, atrial fibrillation, SVT, venous thrombosis, one of the most interesting ones. You may recall in our Jupiter trial that we found that giving a statin reduced the rates of deep vein thrombosis and pulmonary embolism. But remember, in the veins, there's no atherosclerosis, there's no plaque to rupture. And so the hypothesis was that the anti-inflammatory effect of the statin is what drove that. And so we have pre-specified in the cardiovascular inflammation reduction trial also an analysis of deep vein thrombosis and pulmonary embolism. And we have a series of ancillary studies that are actually now being reviewed by the NHLBI that address issues like imaging, issues like peripheral arterial disease, progression of aortic stenosis, things like that.
Well, and that sounds extremely exciting. This, to me, is a brilliant stroke to try and get to this business of inflammatory processes going on with coronary artery disease. Finally, Paul, let me ask you, what's your best guess as to the outcome of this trial?
Well, you know, Dick, it's difficult for me to be unbiased about this. I've spent the last 20-plus years of my career thinking about the way that inflammation affects the heart and the vessels. We began that exploration asking, were there biomarkers of inflammation that could help us understand why 50% of heart attack patients did not have hyperlipidemia? And the clinical use of C-reactive protein has been very exciting to watch in clinical practice as people have begun to understand that inflammation is on par with LDL cholesterol in terms of predicting vascular events. I think one of the most exciting papers of the last year was a very large meta-analysis done from a group in Oxford showing that the incremental value of CRP was actually at least as large as that of LDL or HDL. The Jupiter trial, as you know well, was an attempt to ask the question, if someone has an elevated CRP and would not qualify for any particular therapy, could we give them something that would reduce events and save their lives? And of course, Jupiter showed that if we gave a powerful statin to people who have low LDL, but are at risk because their CRP is elevated, well, we got a great benefit. But of course, Jupiter is not a direct test of the inflammation hypothesis because it's a drug that both lowers inflammation but powerfully lowers LDL cholesterol. So what methotrexate provides us is a drug that does not affect lipids, has minimal effect on hemostasis and thrombosis, but we know is a powerful systemic anti-inflammatory drug, highly effective for arthritis and psoriasis. If this trial shows that giving an anti-inflammatory drug that has nothing to do with lipids lowers vascular event rates, we will have come full circle on the inflammation hypothesis of atherothrombosis. So obviously I'm hopeful that it's positive. I think there's a great chance it will be. I think the observational evidence supports us. I think the vascular biology supports us. The question now is, can we rally all of us to put our patients into the trial, randomize them appropriately, and get good follow-up data?
Well, Paul, that's a wonderful review of a complex subject. On behalf of the ACCEL listeners, thanks for sharing this information, and I'm sure all of us who are anxious to see what happens will be interested in the results of this trial. Thanks again for really sharing this with us.
It's my pleasure, Dick, and I can't tell you how flattered I am to have you as one of my site principal investigators.